Okay, so we are live, Barry. Thank you, everyone, for your time. So today I'm Dr. Nasser, and I'm part of the medical team at Verita Neuro. It's like partly responsible for medical evaluation and overseeing some components of the treatment. I'm with Barry, who is one of our patients from the US, undergoing epidural spinal cord stimulation and stem cell treatment in Thailand at the moment. Barry is an unfortunate victim of spinal cord injury, actually one of the oldest injuries we came across. He was injured around 27 years ago, I think in 1994, and his injury level is C5, C6, quadriplegic spinal cord injury. And so he's undergoing the epidural spinal cord stimulation treatment. This is actually his last week of the original treatment stay. So we would like to hear more from Barry about his treatment experience so far, in terms of the hospital stay, therapies, and everything. So I will appreciate, Barry, if you can maybe give a little bit of introduction about yourself and maybe a little bit brief history about your injury, if you don't mind.
Yeah, that's no problem. And I'm actually C6, C7, not C5, C6. So C6, C6 fracture, C7, basically like explosion, huge fracture. Motor sensory, like motor is C6 complete, teeny bit of sensation, C7. So functional, basically C6, motor sensory, we can say. Injured November 27th, 1994. So almost 27 years ago, so quite a while. Let's see, I've stayed active over the years. Whether it's hand cycling, wheelchair rugby, just going to the gym on a regular basis. And, I've been watching the research on epidural stimulation actually before it even got started. It's at 08, 09, and out in Louisville. And I was watching, actually, I noticed that they started doing the procedure out here in Thailand in 2016, I believe, and just staying up to date because didn't want to be a first subject. I think I was the 101st to have it done out here. And as far as, improvements or post, it's like more spasticity is coming back. I haven't ever had a lot of spasticity. I've never been on meds for spasticity. Obviously neurogenic bladder, neurogenic bowel, hypotension. I use an abdominal binder quite a bit, just to get blood pressure back up. With the stimulator on certain frequencies or certain settings, I should say, the blood pressure is fine. We kind of found that out a few days ago, which is good. It actually feels better than using a binder just because I think it's more venous return, which is a good thing, more blood, nutrients to the heart, to the rest of the body. So better blood pressure is a great thing. I'm sure many of you out there suffer from that. It's the whole reason I came was to see if we could just get some more tone back, more core tone. Functionally, I really had no expectations coming out here, whether it was like increased voluntary control when the stimulator turned on or whatever it may be. But when the stimulator is turned on, it feels great. It's awesome. We're getting on certain settings, we can get some little bit of hip flexion, knee extension. Surprisingly, the quads are still strong. Actually, it's kind of a joke. It's like, they still work regarding the rest of the body. So up in the standing, the E-pacer, we can get the hip flexors going a little bit. The quads are more active. So it's kind of like a march. The more intensity we put in, the more of a march it is. The earlier on, post-injury, the better. We've got a couple guys here that are probably an average of a year out between the two, and they're doing really well. It's awesome to see. So kind of like a veteran in spinal cord injury, not a military, but like a veteran with SCI so many years. It's really cool seeing their progress. And, I have a lot of hypermobility just from little to no spasticity and years in a chair. So hoping to take care of some of that, manage blood pressure. You know, walking, that wasn't the expectation, but, you know, if I can get better over a year, 2 years, 3 years, hey, why not? You know, because I'm so late post-injury. I'm so many years out. So I guess that's a bit of the story. I mean, some of you guys might ask about bladder and bowel improvements, and if it's still early, guys, you know, I haven't really noticed anything there. There's certain programs that can help, you know, help with the bowel program. I've just been so early on, I haven't tried all options yet. So gonna start working on those soon. So one thing at a time, because it's like overload. It's a lot to take in a short amount of time. But you know, when I go back home, we're gonna continue working on it. And I'm pretty grateful for the opportunity to be here, and grateful for the opportunity to do some rehab when I get back home as well.
Thank you for your thoughts, Barry. So I think since I also forgot to mention, Barry is actually a professional athlete from the US. He's a 7 times paracycling champion, and before this, he was actually cycling champion, US cycling champion 3 times. So he had been working extremely hard, although the injury is very, very old. I think the nature of muscle atrophy we had seen in Barry's case is not as extensive as we would normally expect from a patient who had not been doing extensive physical exercise. And we actually could see a little bit of preserved muscle tone, which means that there was probably no degeneration of the lower motor neurons in the lumbar spinal cord, which are actually important when we talk about stretch reflex and muscle contractions. So we do have some important components we wanted before the treatment. And also, I think the cardiovascular function generally is extremely helpful, because sometimes patients are required to go through extensive work. So having a good cardiovascular function, or at least patients who are used to extensive training, are, I would say, a better candidate. So I think this, so this means that all of the patients, at least they should continue with as much as they can, regardless whether or not there is any motor function, because in the future there might be some treatments available, you know, more further treatments or further improvements in existing treatments, and those patients would definitely be a better candidate for those treatments. So Barry, as we understand, you had been doing extensive research. Actually, you had been following the progress being done in terms of the epidural stimulation treatments. I believe you also follow a lot of people who are getting, in clinical trial participants. So basically, so could you please tell us a little bit more about what had you been doing in terms of like online researching, and what finally made you basically convinced, you know?
Yeah, I mean, I'm a clinical exercise physiologist and college instructor by, that's professionally what I do, and a private investor, but that's, that's nothing to do with the research and stuff with this. But I guess, yeah, I mean, just being familiar with research, like in 2005, I did my master's thesis actually on myself with paraspinal strength and tricep strength, because I virtually had none. My triceps on a scale of 1 to 5 are, I think, a 2- and a 2+, left, right. And so, very weak. Functional, yeah, it helps out a little bit with transfers, maybe a little bit with pushing. But we looked at biofeedback and e-stim, so we knew there was something there, which is a good thing. I mean, function of paraspinal is, it's not functional really at all, but you can notice on EMG testing that, oh, well, there's actually something there, regardless of how minute, small it is. But the research has always been something of interest, just with spinal cord injury, because you never know what's going to help someone, whether it's, epidural stimulation, whether it's stem cells, whether it's just intense rehabilitation. It's I guess it's been a passion of mine to stay on top of it. I'd rather not disregard my health and just look for options out there to, always, I guess, in the lines of health promotion, just to maximize what I can do, and over the years. So But I mean, I guess, yeah, I did. I know like Dustin Shilcox, he was the third person, I believe, to be implanted in Louisville. And it was really fascinating to watch just his improvements. And he's still happy with, I actually talked to him fairly recently, and he's still happy with the results and all. And, you know, they're not as limited here by the scope of the research. Like with Louisville is very limited by the scope of research, I think. Just an opinion, but they may be looking at just standing or just blood pressure. And they kind of look at the systemic effects that come along with it over the time. So, I mean, to the end of the study, if they were just focusing on one thing, they might say, well, what other improvements we're seeing? And they look at more all those out here, which, you know, I find to be quite fascinating. And you know, impressive. They've also worked with over 100 people now. So it's just more experience, especially with mapping and finding what works for one person, what may not work for somebody else. So.
Okay. Thank you. Yeah, so mapping is, for those who may not know, is basically, so implantation of the epidural stimulation is one component of the treatment, which is of course equally important. But after the implantation, the most important component is mapping or programming, where we try to find different components of the spinal cord responsible for different functions. So this is a very manual, tailor-made process, basically based on each patient's individual health conditions, particularly the nature of the injury, the location of the injury, and other intact fibers, intact pathways in the spinal cord. So during the mapping process, we find different functions back, which means different contractions come back, for part of the muscle function comes back. And also, I think earlier we spoke about bladder and bowel function, and as Barry mentioned, it's too early. So there is an important distinction between, so there are two components of the motor nervous system. One is the somatic nervous system, one is autonomic nervous system. So for the somatic nervous system, there are direct nerve connections to the muscles. It's easier for us to find direct muscle contractions as compared to autonomic functions, which is a little bit more complicated structure. So for autonomic functions, for example, long-term blood pressure regulation, temperature regulation, bladder, bowel function, sexual function, we normally rely on long-term exposure to the epidural stimulation, so that if you consistently stimulate the spinal cord, it results in neuroplasticity, and over time, it may improve those functions. So I think, yes, I agree with Barry. It's too early to even talk about bladder bowel functions because it's partly controlled by the autonomic nervous system. So in terms of the surgery, I think very many patients, of course, you know, they are concerned about the nature of the surgery, how extensive it is, you know, how do you feel after the surgery? So could you please share your thoughts about the surgery itself? Mm-hmm.
Yeah, I think it was I think it was 4 hours. So I mean, not that long really. I mean, I've had 8-hour surgeries, so it's I guess it's not all bad. But the surgeon, he's amazing. He's actually a really nice guy, very personable. He's implanted more than anyone in the world, from what I know. But no, recovery was easy. People are nice, kind. Yeah, 4-hour surgery, 2.5 days in the hospital. Then to begin, well, I think they begin mapping earlier usually when there's not COVID, and that's been a, you know, the bit of an issue with COVID, and just the whole situation is a little different here. But yeah, it was easy. I don't have any pain. I don't have any issues. If I had sensation, maybe I'd have more pain. I don't know. But yeah, no pain below the injury. No side effect as far as I know. I mean, my tongue was a little bit swollen, but that's just the way my tongue got caught with the trach tube or whatever it may be during the surgery, but no big deal. But yeah, no issues. Staff's great. People are cool. A little bit of language barrier, but Google Translate is great.
Okay. Mm-hmm. So after the surgery, about the initial mapping, what does it feel like generally when the stimulator is turned on? Is it like, does it hurt? Is it abnormal sensations, abnormal feelings?
Some people report different things. Some people said they feel tingling up their body. Like I just get like my muscles contract, so things are more tight when the simulator is turned on. But the biggest thing I notice is that, yeah, I mean, it's blood pressure goes up a little bit, and it feels really good. So I think that's what I noticed the most, just more stability in my chair. You know, one of my favorite programs is when the glutes and the hamstrings are stimulated, and it gets my low back a little bit. And it's like, you know, like sitting posture is great. I feel good. It's like, oh, like it actually feels more normal, just the way you sit the years and years ago, pre-accident.
Okay. And in terms of your the standing training, stepping training, so could you please elaborate a little bit more? Because I think I would like to, of course, it's important because of the very long-standing injury. It's expected that most of the patients would have either osteopenia or osteoporosis, and this is actually
yeah. I mean, I'm 20, almost 27 years post-injury, and I do have osteoporosis. I had osteoporosis 10 or 11 years post-injury, I believe, just like borderline. But yeah, I think I'm one of my 4 standard deviations from the norm, I think, with bones. And I was almost 3 standard deviations from the norm, 10 years post-injury, 11 years post-injury. So yeah, we just have to be cautious on bones. I've never had any fractures, knock on wood. You know, with falls, you know, over the years and banging your legs and just day to day. But so we are cautious. We don't do full weight bearing here. My standing frame at home is almost full weight bearing. So when I get back home, I'll be using that with the standing program, and just stimulating muscles, you know, to work on obviously strength. Walking is going to be a little difficult when I get home. We're trying to figure that right now. So going to find a local therapy clinic. I may end up going back to Salt Lake to do therapy at NeuroWorks in Salt Lake City. We'll see. They're amazing. So I know there's plenty of Project Walks and other similar rehab centers that could do that as well, or just pay somebody, say personally. There's a e-pacer, which is what we use here for walking. So I'll probably purchase one of those, you know, just to gradually increase weight on bones over time and just to be cautious. So yeah, no femoral head fractures are pleasant. What else? But I guess with the standing or the standing and the walking, it's just going to be interesting to see, like when they hold the mirror and they say contract your leg. You know, I could, like, for example, try and contract my quad, you can see it contract. So when I tell it to, which is quite fascinating, pretty cool to be honest. So yeah, I mean, like I said, it's so early, but we'll see what happens with gait training, new step training. And I think just with my hypermobility and you know, atrophy, just doing something as simple as new step to build hip strength, you know, to hip flexors, quads, glutes is going to be essential, just in my opinion, to be better when I'm, you know, walking, standing. But consistency is going to be the biggest key to success, I believe. And they see that in Louisville research as well.
Correct. Yeah, I think we also see, of course, we also, you know, we know patients who are able to do 3-4 hours of training for extended period of time, they are able to see actually better recovery than those who don't. So this is actually very important. And yes, I agree. In your case, it's slightly limiting if we consider your osteoporosis, for example. But I think with the long-term epidural stimulation, because of the improved muscle contractions, the muscle strength, it should help with your bone density also. And once, I think in hopefully in near future, if we reach to a point where we can safely put more body weight onto your legs, I'm quite hopeful that it will improve your standing and stepping ability further. I think so. This is, of course, the next step we have to take in the future. So we are getting a question from Tiffany about mapping. I explained earlier, but maybe Barry, could you please explain from a patient point of view what mapping is, and you know, What does it look like?
Well, if I remember correctly, there's 16 leads on the epidural stimulator, and it's kind of just finding, what lead. Like I'm just like say there's between like leads 1 through 5. Does lead 1, 3, and 5 work better than 1, 2, and 3, for example? We find that like we inverted the blood pressure program on 1 just to figure out what would happen. And it actually works better than the core program, which is quite fascinating. Or it not work better, more it's more comfortable, and it actually holds my abs better, which was, and it differs from person to person. So so we find that like using like the lower leads is good for legs, for example. So they just kind of play with the different leads, and they've done this for what 4 or 5 years now, and they understand what's worked for one may work for somebody else. So when they figure that out, like with my quads, for example, they figured out which leads work best to extend my quads. So that's kind of what it is. It's I think it's a bit of trial and error, but they're very familiar with what's been done in the past with previous patients.
Mm-hmm. Yeah, I think it's quite subjective, and so the thing is, there is no single combination which works for every patient. Even for the same patient during the treatment stay, it may change because there is consistent as a result of the stimulation and the stem cell treatment. There is consistent neuroplasticity rearrangement, a lot of rearrangement going on in the spinal cord. So I think we have to, I think, continuously optimize those settings to find the best possible settings, and then patient can use those settings to train. And we are expecting in the future we may need a little bit of more mapping for for most of the patients because of, again, more regeneration going on in the spinal cord. So we got 2 questions from anonymous attendee. So the first one is, what is success rate? I think it's very so first we need to know we need to define what is success. So I think if we talk about the some functions coming back, I would say it came back in every patient apart from 1 patient where we did not see any contraction at all. So this was a special case where we had actually very long, so patient had a ischemic spinal cord injury, and he had a very long segment of spinal cord atrophy actually. So there was no lower motor neurons, no intact stretch reflexes. So this was the only patient in my experience where we did not see actually any recovery, like 0, basically no contractions at all. Apart from that, we have seen some kind of movements coming back, some kind of functions coming back in every patient we have treated. But then, of course, it's a very big spectrum, from very minor changes to more significant changes, where some of the patients are able to walk with the help of like simplified walker and, have good bladder and bowel functions back. The second question from the same attendee is it possible to gain sexual function with the stimulator? So the sexual function has 2, if I may answer, Barry, it has 2 components. One is actually the cardiovascular function, where we see improved cardiovascular function, improved blood circulation. So this can improve the erection in many patients. The second component is more to do with the sensory function, and autonomic function in terms of ejaculation. This does not happen in many patients. It has happened in few patients that they actually regained ability to ejaculate after the treatment, but not in every patient. So it's one of the components of autonomic nervous system, but some part of the sexual function could be improved using the stimulator. At the same time, most of the patients also get stem cell treatment. So some of them, they get good sensory function back. Some of them moderate sensory function back. So if that happens, this can further improve the sexual function. So no more questions here. Maybe I need to, okay. So
can I say something about that?
Sure, please.
Yeah, I guess, like when I said I came out here with no expectations, I mean, almost 27 years post-injury, it's like you're adapted to life in a chair. So it was like anything, I guess, would have been a benefit, whether it was just more core stability and blood pressure just for day-to-day mobility. Walking wasn't really even a thought, to be honest. It was more, if that comes, that'd be awesome. But what else is going to come along the way? So I guess it's how you see it as well. What improvements do you need? What would be what improvements would be most to you? So for me, it was more quality of life than anything.
Mm-hmm. Yeah, and if you ask me, I think about your response. I think it's not bad, and if we continue with the training in the future, we are hopeful for a better and better recovery consistently. So I think we may achieve more than what we were initially looking for. So hopefully, fingers crossed. How assisted? Okay. Sorry, I don't know where did the question go. How assisted are the patients that are walking? How much assistance do they need? Okay, so the question is how much assistance they need. Of course, it depends on what stage of the treatment you are on. Initially, it's a lot of upper body support, a lot of trunk control with the e-pacer, with the pelvic support also. But going forward, it may become progressively less and less. Some patients can go from like e-pacer to like a standing frame, more like simplified frame or parallel bars. They don't need too much support. So it depends actually on what stage of treatment are we at. Initially, it's a lot of upper body support. Okay. I think that's it in terms of questions. Barry, do you have any? I know you have your therapies in 30 minutes. So do you have anything else to share in terms of your thoughts and any message you would like to give to the audience?
Just one sec. I'm trying to get rid of this box here.
Okay.
I don't know. I mean, I think it just depends. If you want to investigate coming out here, I mean, think about how long post-injury you are, what's your level of function. They do cervical stimulators and lower or T12, L1, T11 to L1 stimulators. So it depends on obviously your injury location, what you want back, how much time you're willing to spend doing rehabilitation. Even research came out of Louisville where people didn't do rehabilitation, 2 people, and they still gained function back. So it's, would I do it again? Yeah, I do it. Just, I mean, I like what I've got so far. I'm looking forward to what's to come. So, what else are you going to do? I guess is a good question to ask yourself. But, it's been good. And, so for me, we'll see what happens down the road. But I mean, the research is, even though it's still, I guess, fairly new to some people, it's pretty solid in many other areas, on what people can gain back.
Mm-hmm.
And yeah, I think I think it matters as well. Sorry, there's a bug in here. If we like see like Asia A, Asia B, Asia C, there are differences, and I think certain categories make more progress than others. It's like if you look at a lot of the research, it's like difference between motor and sensory complete. Are you both? So it varies, as well as time from injury. So the best thing to do is to talk to the professionals, like Dr. Nasir, for example.
And I think, in terms of research, I think it's heading in the right direction. If we compare what was available like 10 years ago, there was, I think the one from University of Louisville was the first proper study on 4 patients involving ES implantation for motor function. And after this, there had been actually, I think, significant developments in various universities, University of Central LA, then we have Mayo Clinic, then we have 2 universities in Canada actively working on, developing new treatments or new therapies involving electrical stimulation for spinal cord. Some clinical trials are going on in Australia and in also in Brazil. And now I think there are at least 17 clinical trials going on for the restoration of like motor components in spinal cord injury. Either it is the somatic nervous system, like the skeletal muscle function back, or the autonomic functions back. So I think it's right, it's gaining momentum, and it looks like this will be one of the treatments in the future, which might be approved actually for very wide scale usage. So I think that's it on our side, Barry. I appreciate you taking time and talking to those who wanted to know about your experience. And thank you everyone for joining.
Yeah, it's no problem. If anybody has questions, feel free to email me, Facebook or Instagram. It's no problem. So
sure. So yeah, I think we will share Barry's Instagram and Facebook for those who would like to talk to Barry directly. And thank you, everyone. Thank you, Barry.